Thank you for joining us for Clinical Snippets in PAH Episode 1. In this snippet, I will highlight key data that was presented at the 2025 fall conferences that were held at PHPN in Seattle, Washington, at ERS in the Netherlands, and at CHEST in Chicago. I'm Ronald Oudiz, and I'm a cardiologist, and I run our pulmonary hypertension program. These are my disclosures, and these are our learning objectives. Upon completion of this activity, participants should be better able to appraise emerging clinical trial real-world and registry data from key 2025 fall conferences that we just mentioned to enhance early detection and timely intervention strategies for patients with PAH, to interpret updated risk assessment tools and prognostic models from these conferences presentations, to tailor treatment pathways based on individual disease severity and progression, and to integrate evidence-based strategies and novel therapies into real-world clinical decision-making for patients with PAH. So this is part one of the clinical snippets. And in part one, we're going to start off with PVDomics. Now, PVDomics is a registry of PAH individuals, patients, where they've collected data, not only genetics, but they've also collected clinical data, including echo and RV function. And this is really important because as we look at risk factors and risk analysis, many of our risk score tools actually don't incorporate echo to the extent that they could. So what they did is they took 405 PAH patients from the PVDomics registry, and they used linear regression to assess associations with walk distance, exercise capacity, and also these Compara and Reveal Light risk scores that we're so used to using in the clinic every day. There is something called penalized Cox regression that was basically the statistical method used to develop new models that combine prior risk score with the enhancement of echo parameters. And then there was cluster analysis combined with survival analysis used for prognostic significance. So in this presentation at CHEST, some of the key findings were that obviously reduced RV function was linked to higher BNP and worse exercise capacity and higher risk. But when they looked at the C statistic, which is the area under the curve when you're looking at the ability, predictive ability of a model to predict outcome, they saw that the C statistics were enhanced somewhat by adding the echo variables. So you see all these different scores and the C statistics associated with them. And then when you add RV echo to Compara or Reveal 2.0 Light, you see that this C statistic goes up into the 0.88 range. So the echometrics improved risk models by up to 10% if you look at that gain from a C statistic standpoint. And it turns out that severe RV dysfunction gave you up to a threefold higher risk of mortality after adjustment for all the other relevant co-founders. So the takeaway is that incorporating detailed echo assessment of RV function enhances prediction in PAH, really not earth-shattering for those of us that are in the trenches doing this, but it lends some credibility to the idea that, yes, you got to look at the echo. When I teach our fellows in the clinic and they give me a risk score, I say, well, what's missing? The echo is often missing. Let's look at the echo. Don't read the report. Let's actually look at the echo. So now there is a systematic literature review using PubMed and Google Scholar from a presentation at CHEST where they were summarizing predictive models based on those models that were statistic or machine learning models. And this included 80,000, more than 80,000 PH hospitalizations across 5 different studies, where they looked at some of these obvious predictors of outcome, which were in the clinical realm: heart failure, kidney disease, anemia, electrolyte and fluid abnormalities, liver disease, and chronic lung disease, all associated with higher risk, as well as the demographic, in this case, younger age and male sex, particularly in scleroderma PH, and then socioeconomic limitations, public insurance versus private, were higher risk. But what was interesting was home oxygen use somehow translated to a lower risk. So 30-day readmission rates were somewhere around 20% at 30 days and up to 34% at 12 months. And it was driven by comorbidity burden and socioeconomic factors. These common predictors you see here that we talked about, and the model performance was modest, with a C statistic only around 0.6 to 0.7, and machine learning may be slightly improvement, kind of at the top of the statistical model. And then home use appeared protective, and we can maybe discuss offline why that might be and some of the biases in studies like this that look at large, big bite populations. But the takeaway here, as you see, is readmissions in PH are common and multifactorial, and predictive models for readmission may offer acceptable ways uh, to determine your outcome, but have obvious limited accuracy. Now, another retrospective data registry review looking at the comorbidity burden to examine how cardiovascular or respiratory comorbidities can affect response to PAH targeted therapy. So the primary outcome here was improvement by at least one ERS ESC risk class and 228 newly diagnosed IPAH patients with baseline hemodynamics and comorbidity data. So the numbers are small, but remember that we're dealing with purely newly diagnosed that are prospectively followed. And what they found out was maybe not unexpected, but each additional comorbidity, cardiovascular comorbidity, reduced the odds of improvement with therapy, blunted, if you will, the improvement by about 27%. So there was no difference in the response to therapy between patients with or without comorbidities with a single comorbidity, but when you added them and started stacking them, it made a difference. And the respiratory, and particularly respiratory comorbidity, added an additional blunting of the response to therapies. In fact, maybe if you look at the next slide in a second, you'll see that they were more strongly reducing the likelihood of improvement than the cardiovascular comorbidities. But regardless of clinical severity and other confounding factors, an increase in the number of PAH-specific drugs administered to patients is positively correlated with clinical improvement. So you could look at two sides to that. One, you would think that if you needed more drugs, that maybe you were sicker and weren't going to do well. Or two, if the fact that you were using more drugs is evidence that you are aggressively treating, you might expect an improvement. And that's, I think, what they saw here. So this table kind of plots the differences in response to therapy, the percent predicted probability of response to therapy based on the number of comorbidities, either respiratory comorbidities on the y-axis or cardiovascular comorbidities on the x-axis. So you can see if you had 0 cardiovascular comorbidities, but 2 respiratory comorbidities, your predicted probability dropped from 0.70 up here on the upper left to bottom left 0.48. But you can similarly see that if you had no respiratory comorbidities on the top row and you went across to the right, that you had a decrease in the predicted response to therapy. And that higher number is the darker color. So the lighter you get as you go over to the right or from top to bottom, the worse it is. Maximum here where you had the most cardiovascular comorbidities, 5, and 2 respiratory comorbidities, your predicted probability of improvement is down to 0.16 or 16%. So the takeaway here is comorbidities should not preclude the use of PH treatment, but they do require personalized, cautious management and will likely end up blunting the clinical response to therapies. So another retrospective cohort review, this is looking at the National Readmission Database that is based on ICD-coded comorbidities. All the concerns about ICD coding and whether or not this is a valid way to look. This is the best we've got when we look at big bites often because we have to assume that most of the ICD codes were assigned appropriately. In any case, this is anybody that was hospitalized with a primary diagnosis of pulmonary hypertension. And over the years, from 2010 to 2021, systemic hypertension coding, presence, if you will, of systemic hypertension decreased by almost 60%. And the authors say that the decline in hypertension prevalence in later years could reflect changes in diagnostic coding or shifts in population demographics. What they didn't say is maybe that when we're more properly coding for PH patients and more appropriately recognizing that PH is the primary coding abnormality, the primary presenting abnormality, and these patients often are, if they were hypertensive, are no longer, and often hypotensive, that could be it as well. In any case, obesity trended upwards from 22.7 to 31.4. CKD trended upwards as well from 12 to 21. PE-DVT history increased and COPD increased as well. Atrial fibrillation and diabetes, however, remained stable. This is a plot of those trends over the 2010 to 2020 time point. And here's where you can see this hypertension is probably the most obvious drop from 60s into the 40s. Key takeaway here, again, is understanding comorbidities and the trends in comorbidities may aid in optimizing management strategies and certainly help us figure out what kind of expectations we might look at when we're treating. And even in designing clinical trials, it's incredibly important to understand the impact of comorbidities and the interplay between the various types of comorbidities. So, what about long-term survival in patients with comorbidities by risk class? So, this is a retrospective analysis of a multi-center registry cohort, albeit a small multi-center cohort, 114 patients with idiopathic or heritable PAH and CTD PAH classified as either classical PAH with no comorbidities, 42 patients, or PAH with one or more comorbidity, 72 patients. You can see the mean age was 33 for the classical, and the mean age was 68. Most were female in both cohorts. If you look at the upper right, the mean pressure at baseline was higher for classical PAH than those with comorbidities, 49 versus 39. The percentage of upfront combo therapy was higher for classical PAH than for PAH with comorbidities, perhaps reflecting the caution that one might have when there are comorbidities. And the 10-year survival rate for classical PAH was significantly higher than for PAH with comorbidities, suggesting that these comorbidities obviously have to be considered in that interplay we were talking about before. This looks at the plot over time in the classical PAH, the survival rate beating those with PAH with comorbidities. Key takeaway here is 10-year survival rate for those patients without comorbidities significantly higher than with one or more, and unfavorable outcomes for those with comorbidities may be due to the lower proportion of patients who can tolerate upfront combination therapy. So part of that maybe is the mitigation, if you will, by the prescriber of those comorbidities, perhaps, or the caution may be a better word than mitigation in using multiple therapies, but maybe that's coming at a cost. That's one speculative possibility. Just in summary, then, when we look at echo data and how it enhances risk prediction, I've been professing this from day one. Echo is incredibly important because it's the RV that determines outcome in most cases of pulmonary hypertension. And adding RV echo metrics to the Compare and Reveal scores improve prognostic accuracy in PAH patients. And I don't think we can emphasize that enough. You've got to look at the echo and incorporate that and not just do risk scores in your clinic when you're deciding on how to continue to therapy or add additional therapy. Comorbidity, of course, the burden limits or blunts the treatment response. Both cardiovascular and respiratory comorbidities were presented just this fall. They reduce the odds of clinical improvement, underscoring the need for individualized treatment strategies. And then long-term outcomes are worse in PAH with comorbidities. They have 10-year survival that are worse, and they're less likely to receive upfront combination therapy, again, highlighting the importance of early risk stratification. Thank you again for joining us in this clinical snippet in PAH. Please be sure to return to the activity webpage and click continue to move through the post-test and evaluation questions to claim your AMA, ANCC, or ACPE credit and access the downloadable slides. Thanks for staying with us.